um, in most, sorry about that, in most states in the US. And we had a National Commission on Certification of Physician Associates. So that was kind of the medical council for us, for PAs in the United States. And that came with accreditation recommendations and recommendations for education. So how are PAs trained in the US? It's a very intensive between 2 to 3 year master's degree. My program was 1.5 years. I mean, 2.5 years. And it is very intensive. It's year-round, full-time. You don't get summers off. You don't get a Christmas break. You just go to school. To be a candidate to get into PA school, you must have a bachelor's degree. You have to take certain pre-med prerequisite courses, including things like, of course, anatomy and physiology, biochemistry, all of those pathophysiology. And then you generally need a minimum of about 2,000 hours of some kind of patient contact experience to actually be in the running for a slot. It's incredibly competitive programs to get into in the US. We are trained as generalists in the medical model, so we're not trained to follow a certain path. We're trained just generally. And the first year is usually in the classroom. Many of our classes are taken alongside medical students. For example, in my program, we did cadaver anatomy and physiology with the medical students. We took pharmacotherapy with the medical students. And then, of course, we get trained in every aspect of the body, cardiology, ENT, pulmonology, everything. And then the second year and a half is generally clinical rotations out in the community. So all PAs will receive somewhere around 2,000 and most of the time over that clinical rotation hours. And you have to spend 3 months in general practice. You have to spend 2 months in emergency medicine, at least a month in hospital doing in-hospital training, pediatrics, gynecology. You cover all the bases. And we're taught to be very versatile and collaborative, hopefully. So certification is through the NCCPA. In the US, it's a little bit different than New Zealand in that the NCCPA is the only national certifying body for us. And then you actually get your medical license to practice from whichever state you happen to be living in. So my initial license was from the state of Oklahoma. And then when I moved to Washington State, I just applied for a medical license through Washington State. But our certification is national, and all PAs have to have this certification. So initially, once you graduate, you take this terrible 5-hour multiple choice written exam that covers everything, general medicine, surgical knowledge. In the UK, they also have to do OSCEs. And then once you pass that, that's how you get the little C at the end of your name, PAC. To maintain that certification, we have to do 100 hours of continuing medical education every 2 years. 50 hours of that has to be something in person. So like going to the CME conference or studying, going for training, something along that line. We call that category 1. And then the other 50 hours can be journal reading or articles or other kind of learning that you can put in there. In the UK, they have to take a recertification exam every 6 years. I think that might be changing. And in the US, it's every 10 years. Although it was every 6 years when I graduated in 2004, now it's every 10 years. But you have to take the same certification exam, and it's just as atrocious as the first time you took it. So what can PAs do? Once we have our degree and we have our certification, then we can function in the US somewhat autonomously. We obtain medical histories, do physical exams. We can order and interpret labs and imaging studies. We can make diagnoses. In the US and Canada, we can prescribe medications. We can perform minor surgeries, can assist in major surgeries, like in an actual OR. We can monitor and manage hospital inpatients. And our scope of practice generally mirrors that of our supervising physician. So an example of my everyday clinic, I'm still at clinic today, so I'll tell you how my day went. I start seeing patients at 8:30 and I work until 5:30. And I generally see 3 patients an hour and then have some admin. And the patients I've seen today were A 6-week check, someone with bilateral leg swelling that's been ongoing for a while. I saw a strep throat. I saw a shortness of breath and cough. I saw a query stroke, which wasn't actually, thank goodness, hopefully. Headache. I do a lot of women's health. I put in a Mirena. So just kind of everything that a GP would generally see. I'm able to see those patients because I have experience doing those things. And my supervising physician can do all of those same things as well. And so that's how I'm able to see that. In the US and Canada as well, because we're trained as generalists, we can change specialties. So in my career, I started out in general practice, and for the first 5 years, that's what I practiced. And then I moved to an ear, nose, and throat specialty, and I worked for 2 years with a head and neck cancer surgeon. I, of course, didn't do surgery, but I worked in the clinic, and I did histories, and I did post-op wound care, and I did follow-up. All those sorts of things. I've also worked in palliative care in hospital for a while, but the majority has been general practice and urgent care. So what type of patients do I see? I kind of already went over all this. Whatever patient walks through the door, whoever wants to see me, whoever needs to be seen, and I happen to have a slot open, they will come and see me. We really are trained to know our limits. I can't tell you how much that's drilled into us in PA school. You are not a doctor, and if you don't aren't sure about what you're doing, you need to ask someone. Don't just go in there not knowing exactly what you're doing and take a chance. You need to make sure that you ask if you need it. So PAs are actually in lots of places all over the world. Of course, we know the US, Canada, the UK, Netherlands, Australia, Germany. They've got PAs in South Africa, in Israel, Liberia, lots of places. They don't all function the same way as PAs from the US, UK, and Canada do. In some countries, they're much more specialized. So they only work in cardiology or they only do women's health. They're not as generalized. So how do PAs get in New Zealand? Karl will tell you more about this in a moment, but between 2010 and 2015, there were two PA pilot trials that were started. There were two surgical PAs in Middlemore Hospital, and then later we had 7 PAs in various rural clinics around the country. At the end of those two pilot programs, Health Workforce New Zealand, who is the group that I think promoted the second pilot, and Karl will tell you more about the first one. They also hired Synergia, who's a research firm out of Auckland, to go in and get surveys from the patients that were treated by PAs, to talk to the doctors, nurses, clinic admin, anyone who had worked with PAs during the pilots, and kind of get an idea of how we were, how receptive they were to the idea, if patients had any complaints, how people felt about working with the PA, and it was overwhelmingly positive. Over 90% of patients were satisfied with the care they got, and over 90% of nurses who worked with PAs were happy or were satisfied with the work that they worked with. So based on that, the New Zealand Physician Associate Society was formed, and in 2017, we filed our application for regulation. While we were waiting for that to go through in 2020, we paired up with the Australian PA Society and started an Australia and New Zealand PA Standards Council. And in 2020, we finished the work to come up with accreditation procedures for PA training programs in Australia and New Zealand. In anticipation that we would eventually want to start a PA training program in New Zealand. And so we've got that ready to go. In 2023, our application progressed through the expert panel stage and the targeted consultation phases. And then this year, we've had lots of exciting things happen. Our application was approved by the Minister of Health, and we are currently working through assignment of a regulatory authority with the Ministry of Health. And we are hopeful that there will be a cabinet vote on our application by the end of this year. The minister has actually been terribly supportive of us, which is really great. And he also he had mentioned that he would like this to be done by the end of the year, and also that he would like a PA training program to be in effect within 5 years of regulation being completed. So we're all on board for that. Now, one big question we get a lot is, how do we practice without regulation in New Zealand? Through an agreement with the Ministry of Health, based on the success of the pilot programs, PAs are allowed to practice in New Zealand if we are regulated in our home country or if regulation is in progress, like in the UK. So basically right now, the 3 countries that PAs can come from and work in New Zealand are the US, Canada, and the UK. We have to maintain our national certification from our home country. So I have to keep my NCCPA certification up, and the same for other PAs who come in. And this has to be kept on a publicly available voluntary registry, which is part of what NESPOS does, or the PA Society. We are tasked with keeping a list of PAs currently practicing in New Zealand, and we have to list their certification number as well from their country. We have to maintain our own malpractice indemnity coverage. All the PAs in New Zealand have coverage through either Medicus or MPS, mostly through Medicus right now. And we can only work within the same scope of practice as our supervising doctor. And all prescriptions, lab orders, imaging orders, referrals, anything that needs a provider who has a medical license number in New Zealand on it has to go through our doctor, or it has to be put under their name, because obviously we don't have our own medical licenses right now in New Zealand. Okay, where are we? Gosh, we're just everywhere. We mostly North Island, that's where the majority of us are right now, but we are expanding to the South Island. Super excited about that. There are 48 PAs currently practicing in New Zealand, and those 48 are spread between 27 different clinics, which I think is really telling about how clinics feel about the care that PAs provide to their patients. Because most clinics, once they have one PA, they want another one, or they want 2 more. My particular clinic in Papakura has 3 PAs, myself, and then 2 UK PAs. And that's the only reason we've been able to keep our books open and continue to accept new patients, is because we have enough people on board to take care of the patients. So looking forward, what are our goals for the future? Of course, continue to recruit and retain PAs, mainly in emergency medicine, general practice, urgent care, the type of providers that we really need in the rural areas. And we like to promote rural and remote areas. Promote the PA role throughout New Zealand, of course. Regulation, oh, that's like the ultimate. We can't wait for that. And also we hope and we feel like prescribing authority needs to be part of that regulation, and we think it probably will. All the discussions we've had with the Ministry of Health and with the 2 prospective regulatory authorities have indicated prescribing rights would be on the books, because otherwise it would really hamper how effective we can be, and it won't allow us to practice to our full scope. And of course, create a PA training program. That's been something we want to do from the very beginning. We have been in talks with Otago Medical School, Otago University. They're very keen to have a program, but of course they want us to be regulated first, which makes sense. They don't want to start a program for an unregulated profession. And so we hope that will be on the books in the future. All right. And that's all for me.
Great, thank you so much, Shelly. It's really valuable to get that oversight and see some of the detail around your experience and your training to date. And from my own research, I see there were trainings for PAs in Australia, and because they weren't regulated, that sort of fell through and collapsed. So I can see the emphasis that's been placed around regulation and the importance of that in terms of maintaining standard and having a professional pathway is so valuable. Please, reminder again to get those questions into the chat, and we'll keep an eye on those. What we'll do is we'll keep moving through our speakers, and then collate and address our questions at the end, if that's all right with everybody. Nice to see everybody's up to speed on the etiquettes of Zoom and keeping your microphones muted. I forgot to mention that at the start. Yeah, so let's kindly invite Karl to open his video and share with us his experience as CEO of Core Health Limited. Karl.
Thanks, Jeremy. Kia ora koutou whānau. Ko Karl mesa toko ingoa no Awherika hau e mahi ana o te hauora o Morua wai he tumu whakari ta haku mahi. He o ranganako he pikinga waiora. Nō reira, tēnā koutou, tēnā tātou katoa. Thanks for having me this evening. Marie, are those my nostrils or Jeremy's you were looking at?
Yours.
Mine, thanks for that. How rude.
I wrote that privately to you.
Nothing's private with me. So I just starting out, I want to just acknowledge Shelly and Collins and Lisa DeWolf in particular, and Tiffany Hodgson as well. They've done an enormous amount of work over the last year or so in terms of moving the discourse forward really towards regulation, and have done an enormous amount of heavy lifting in getting us this far, and fingers crossed for early December with Cabinet. So by way of context, for those who don't know, Causa, a not-for-profit community-owned trust, healthcare facility, 20 inpatient beds, 24/7 ED. We have a primary birth and maternity unit. We do about 100 births a year. We've got a 6,000 enrolled primary care practice, 3 private dental surgeries on site, and have a MolMap NZ franchise that looks after most of the South Island. So by way of context, and Shelly's touched on a lot of this, and I know people will be getting hungry, so I won't drag it out, but in 2010, the pilot of pilots happened at Counties Manukau with the support of then Professor Dr. Des Gorman, who was on a board member of Health Workforce NZ, and he brought out the 2 surgical PAs to Counties Manukau DHB to join the acute surgical team. And from then, we were approached in 2012 by Dr. Priyesh Tiwari, who was both a friend and close colleague at Health Workforce NZ. And he was instrumental in championing the pilot of 7 PAs, bringing them out to New Zealand from the US. Gore Health was the first and only South Island pilot site to employ a PA in the emergency department. All the others were on the North Island and based in primary care. We had the absolute privilege of employing Liz Gamelin, a PA of 15 years with rural experience from the Teton Valley in Idaho. And Liz and her family joined us for almost 3 years very successfully. And we've now been employing PAs for over 12 years, predominantly in the ED, up until earlier this year, where we employed our first PA in primary care. I have to say we wouldn't have been able to maintain ED services 24/7 had we not had the PAs. And we also would have probably really struggled to retain our existing medical officer workforce, given the workload and burnout probably levels that would have accompanied being short-staffed. Despite the decade-long struggle to lobby, advocate, and support the formal regulation of this profession, the enormous value they have added to our community's health and well-being is immeasurable. We made a decision many years ago to philosophically support the recruitment of PAs based on the rationale that the fact that they had come out of the most medico-legally litigious society on the planet and are wanting to work in one of the least litigious countries was somewhat comforting. That said, all PAs entering New Zealand to work in clinical settings are fully insured and indemnified by Medicus Insurance NZ, and agree to undertake formal supervision and oversight by suitably qualified medical doctors. I can say that in 12 years of employing PAs to date, touch wood, we've not received a single HDC or formal patient complaint, whether that be around clinical treatment nor attitude or behaviour related. Sadly, that's not always been the case for some of our regulated workforce. There's no bigger supporter of PAs than myself. I can honestly say that I've written to every health minister since 2013, lobbying for their formal recognition and regulation as a profession and a genuine solution to rural and health inequity. That includes Ministers Ryle, Coleman, Clark, Little, Verrill, and more recently, frequently Ministers Patterson, Ducey, Seymour, and Retty. I have the letters to prove it if you want to see them. I'm firmly of the belief that the workforce challenges we face in Aotearoa require an and solution, not a patch protective lens of the world that fails to take into account that there will always be more demand than people to meet the demand. Equally, Gore Health has invested heavily in a grow your own approach when it comes to our nursing workforce, having now trained and developed 4 nurse practitioners, all of whom live locally and work very closely and very well and collaboratively with our PAs. Ironically, despite PAs not being regulated, they are on the highly skilled or formerly hard to staff list with Immigration NZ. Go figure the irony. If the prime objective of the HPCA Act is patient safety, then it makes absolutely no sense for the patient-facing role of the PA profession not to be regulated. Make no mistake, supporting this profession and its road to regulation has not come without its challenges. I've had to front many highly critical and public nursing and medical forums. And that's okay. I respect that change is always uncomfortable, but I don't accept blind, ill-informed criticism. Sadly, all too much of the criticism fails to take into account the rigorous training and exceptional clinical acumen this workforce, now numbering over 160,000 in the US alone, possess. If you're interested in recruiting PAs, happy to chat further, and hopefully that may come up in question time. In terms of selection, and not wanting to teach my rural colleagues how to suck eggs, but I think we all know fit is critical, and I would strongly suggest employing PAs that have a minimum of 5 years experience, depending on level of your rurality and isolation and level of autonomy that they'll need to work in. For our ED setting, it's critical that they are confident and suitably skilled to work solo in ED, with oversight, obviously. Generally, we look for PAs who have a strong affinity to rural lifestyle, have a bit of a loner profile, and are very comfortable with their own company. Many of ours have spent time on the ice in Antarctica, for example. Retention-wise, my advice would be to keep expectations real. For many New Zealanders, still a novelty experience, and bank on about a 12 to 24-month tenure. That said, with regulation, this could change. Not being regulated is understandably frustrating, but by no means a barrier or showstopper. For me, success looks like Cabinet passed the bill to regulate, and in 3 to 5 years, Otago and Auckland medical schools have developed curriculum and programs, perhaps even alongside a new Waikato school, who knows. I often hear the argument that PAs are cheaper than doctors and will undermine both the medical and nursing workforce. In reality, whilst using PAs over the past 12 years, I would say a back of the envelope has probably saved us an estimated $3.5 million in direct, permanent and locum costs. However, current salary and terms and conditions are on a par with New Zealand nurse practitioners, and my prediction is those will likely rise with regulation and the usual supply and demand market forces. Thanks, Jeremy.
Kia ora, Karl. Thank you for that. It's really interesting, and particularly to get these different perspectives. And obviously, as the CEO of Gore Health, very much around making sure the books are balanced and what's financially viable to keep your service afloat, and both in terms of the actual cost of PAs, but rather supporting that existing workforce as well is really interesting. And so now welcome to the table, Scott Davidson, to bring the clinical component to it, which I think is a lot of the concern that many of us have around how do we support, how do we supervise, how do we work with clinicians like this. Kia ora, Scott.
Kia ora, tēnā koutou katoa. I'm a GP primarily. I don't work too much in rural hospital medicine now, but I also have an interest in ophthalmology and work one day a week at Whangarei Hospital. But essentially, in our practice, we've have 2 PAs. One is on maternity leave at the moment, but when 3 of our partners retired in 2020, we'd been looking for a long time for replacement GPs and just couldn't find them, and including locums. So we've dropped from 11 partner GPs down to 4.5, and we were very pleased to be able to recruit Jamie, who's our first PA, and primarily we recruited her on the word of mouth on how good physician associates were from Cheryl Britton in Kaitaia. And we also in our practice have a clinical pharmacist who's a prescribing pharmacist, and we have a nurse prescriber. We don't have a nurse practitioner. We certainly would employ one if we could find one. But we certainly have had an excellent experience with our PAs. Both of them have been paramedics prior to doing their PA masters and training, and both have had significant experience over 5 years of being a PA in the US, primarily in rural practice, in either family medicine or the emergency department. So they're both very skilled. They've got a very good procedure skill set. They're primarily used in our practice for seeing our drop-in A&M patients. And our practice probably sees, on a busy Monday, we might see 80 or 90 patients drop in to that clinic. We are trying to expand that a little bit so that they can follow patients up more and have regular booked appointments. But at the moment, they're primarily seeing drop-in patients, urgent care patients. Because of the lack of regulation, and because we have to sign all the prescriptions, essentially we have one GP now on that drop-in clinic, whereas previously we had two. And that GP who's on has to review all the patient's notes from the PA and re-prescribe all their prescription items. And we have noticed a slight difference in prescribing pattern, and that may be a US thing, but on the whole, it's very seldom that I change what a PA has prescribed, because I prescribe things slightly differently. And we have certainly had high patient satisfaction with the care they've given, and I've been very impressed by their abilities. So we've had a very positive experience of having PAs, and it would be difficult really actually to run our practice without them. They're very productive. They're well trained, and it'll be nice when, in fact, the regulation comes through and they get prescribing rights, because that will lessen my number of prescriptions I have to write a day. So that's probably as much as I need to say.
Yeah, thanks, Scott. I appreciate that.
If anyone's got questions, very happy to respond.
Yeah, perhaps if I can keep you on the mic, and let's talk to Victoria's comments. Thanks, Victoria, around that vicarious liability, in particular around responsibility for tests. I know it's been a huge issue with patients discharged from hospital, GP to follow up results. Where does that responsibility sit? In your experience, how have you found that concept and being responsible ultimately for that decision making, and particularly the investigations and so forth?
Yeah, well, vicarious liability does mean that for us, we feel like as partners in the business, the buck stops with us, and that includes from everyone. It's not just our PAs, it's our locums that are telehealth locums, it's it's our nurse prescriber, it's our nursing staff. So how do you manage that? Well, it is difficult. And it's something that we do talk about regularly. At the moment for PAs, it does mean that actually we're reading all of their notes. We're not doing that for our other regulated staff, our nurse prescriber, our clinical pharmacist, but they're regulated. So, I think when regulation comes through, we can relax a little bit on that. For our PAs, but yeah, we haven't had any complaints from our patients. it's interesting. The patients, in fact, it's interesting that over the last couple of years, the number of patient complaints we've had for the whole of our practice has decreased significantly, and our workforce has decreased significantly, and the length of time to get an appointment has increased significantly. So I think maybe patients, appreciate that we're now super, super busy, and maybe they're giving us a little bit more slack. I'm not sure, but yeah, the vicarious liability is something that does get discussion by the partners in our practice.
Yeah, thanks, Scott. As MC, I suppose I get the opportunity to also dominate the questions. But one thing that's really interesting for me, we as a country, we rely so much on our international workforce, whether it's doctors, nurses, across the whole board. One of the real issues is around clinical practice in Aotearoa is unique, has its unique challenges, and particularly, and we have legislative requirement to be culturally safe. A question perhaps for you, Shelly, how can we ensure that these clinicians that are coming in can meet that requirement around cultural safety, and how do our rural communities support them in that role, particularly around contextually appropriate and culturally safe practice?
Yeah, thank you, Jeremy. I think that's a really important question, and I do hear that a lot. But I will say I go through the same cultural training that everyone else in my clinic goes through every year. And so I complete the same training. I do training about the Treaty of Waitangi. I learn the history that all other practitioners have to learn. And I will say that a lot of PAs, like I'm from Oklahoma, that has a huge Native American population. So when I practiced in Oklahoma, I had to be aware of Native American practices and cultural sensitivities in that way. And I think most Americans understand that. And I think most PAs, even from the UK and Canada, would be aware of that. So I don't feel like we would be insensitive to those cultural issues when we come over. But again, like I said, we have the same training that foreign doctors who come over, foreign graduate doctors who come over, we do the same kind of training that they go through as well before they start practicing. I will say when I was in Kaitaia, they did an amazing job of helping train because they're mostly locums doctors in that particular clinic. And we took ukulele lessons and we learned some te reo and we sang and we did all kinds of wonderful cultural things to kind of get us acclimated to the culture. And I experienced that in South Auckland in Papakura. We have a huge, I think it's about 50% of our population is Maori or Pacifica. And so we really have to be aware of those cultural differences. My clinic's very supportive and we deal with those every day.
Yeah, thanks, Shelly, for that. I'll perhaps go to some of the online questions that were posted earlier. And the generalist scope, I think Shelly has talked to around how we train people to work in a generalist scope, and that was covered really nicely. One thing that is a concern is around terminology, and there's the talk about doctors and various things that are bandied around, and patients not necessarily knowing the scope of the clinician that they're seeing. Is there an opportunity here to redefine or use different terminology within the New Zealand context around physician, particularly physician associate? What are your thoughts on how we describe the role so that patients best understand the context and practice in which they work?
Right. So I do have to explain that to my patients on a daily basis. They come in, I say, hi, I'm Shelly. I'm a PA, physician associate. And they will say, what's that? Never heard of that. And so I reply to them, well, it's a master's level degree and it's similar to how nurse practitioners practice. We're not doctors, but we're kind of mid-levels somewhere in the middle. And I've had this amount of training, and then at that point they've zoned out and they don't care about the rest of it and they just want to be fixed. And so and honestly, at the beginning of every visit, I'll say, I'm Shelly, I'm a PA. And by the end of the visit, the patient will leave and say, thank you, Dr. Shelly. And they call me that regardless of what I say. But I've been referred to as the nurse. I've been referred to as the doctor, to the PA. I think as long as patient care is appropriate and patients are being taken care of, that's the most important thing. I don't know of any PA who is parading or pretending to be a doctor, and that's not what we're trained to be. That's not what we want to be. Um, and so we do go above and beyond to make sure patients know that we're physician associates and try to explain what that role is. And on the days I wear scrub, I have my name on it that says Shelly Collins, PAC, so that they know that I'm not a doctor.
Yeah, thanks, Shelly, for that. Again, the questions are probably best answered by you in many contexts, but others, Karl and Scott, feel free to jump in. And similarly, others who are on the call who feel like they are able to contribute, please put your hands up to answer. One thing we've seen in context around workforce stuff and telehealth, and particularly, is this a substitute for a clinical workforce? And I guess there's a concern and anxiety around, if we are able to recruit PAs and appropriately so in community, is that going to be seen as therefore, okay, boxes ticked, and then we don't need to also build our general practice, our nursing, our allied health workforce as well? Do you see that as an issue, or what are your thoughts on that, Shelley?
I don't see it as an issue at all. For one thing, for physician associates, for PAs, we are not allowed to open our own clinic and practice, completely by ourselves. So you will always have to have a general practitioner. You'll always need a GP or a supervising doctor on board in order to even hire a PA. And of the 27 clinics who've hired the 48 somewhat PAs in New Zealand, not one clinic preferred a PA over a GP. No clinic said, oh, I'd much rather have a PA than GP. They all got a PA because they couldn't find a doctor. They couldn't find a GP. They couldn't find someone to work in their rural clinic. And so that's how they came upon the PA profession to begin with. I feel like there's plenty of work for everybody. I don't think we're going to take anyone's job for sure. And we're all on board. I support the idea of training more doctors, training more NPs, nurses. We need more of everything, I feel like. Um, but I feel like medicine in general, in the US, in the UK, and Canada, this seems to be kind of where the medical model is going, medical practice model. It's no longer the GP on top, and then, they make all the decisions and everybody kind of does what they're told to do underneath, or what comes down from the top. It's much more a team-based process now. And I will say, talking to the GPs in my own office, they have mentioned that they actually like that idea because they don't feel like they're the ones who have to make all the decisions all the time. For example, we have nurses who kind of run their own same-day acute care sort of clinic. And so at least a dozen times a day, they will need to come and talk to someone about that patient because it's outside of their scope. And it used to be the two doctors. They got all of those questions. So not only did they see their own patients, but they had to go check on the nurse patients. And so now they've been able to kind of farm out that task to other people.
Thanks, Shelley. Perhaps naively, because I'm in the space and I'm passionate about rural, but I think that's also an opportunity and a strength of rural, because we don't have the hierarchy that you often see in urban type environments, and that opportunity to work as a team and really utilize and build off each other's skills, I think, is a real asset for us in rural, and give us this opportunity to embrace and help serve our communities with this sort of expanded type workforce. Just want to
Can I
change.
one more thing? I'm sorry, Jeremy,
Yeah.
just for a second. The question about liability. I understand that question definitely. And as one doctor said, getting a PA right now before we're regulated is not for anyone who is terribly risk adverse. You have to have a little bit of faith and be willing to jump into it. But also a good example, because everything goes under my supervising doctor's name, everything I order, everything that comes back, all the labs, all that comes back into one inbox. So he and I both work on the inbox together. And an example of how we can work together that way is he was on vacation. He had ordered an ultrasound on a patient. The ultrasound came back while he was gone, and it was a query cancer or possible cancer. So because I was checking the inbox as well, his inbox, I was able to get that patient referred to the oncologist and on their way by the time he even got back from vacation. And so we work well together, I think, that way.
Yeah, thanks, Shelley. So just to change tack a little bit in the questioning around, the actual overall cost saving, and I know there's been good evidence around, the difference in clinicians. And if you see a senior GP, the likelihood of getting referred to a specialist service or getting over investigated is often better managed by a well-experienced rural GP. Indeed, we've got junior doctors as well who over investigate, over refer. And I just wonder if you can speak to the questions both in the chat and also received personally around that cost to the whole system, around increased referral rates, increased investigation. What's your experience in that? Do you know of actual cost? Is there evidence around it, or is it anecdotal perhaps?
I think it's more anecdotal. There haven't been any specific really good widespread studies that I have come across that have shown there's a huge difference. But I think people are right. I mean, PAs, because we know we're not doctors, we maybe tend to order a little bit more than the experienced doctor would. But I would also make the argument that an experienced PA would not overorder as much as an inexperienced PA. And I have to tell you, New Zealand knows what they're doing with this whole pathways thing. I mean, that's amazing. We don't have that in the US, where I can just get on pathways and, it tells you exactly what to do next whenever you have a patient with this particular thing, who to call, what to order, when to do the next thing. I think that really levels the playing field to kind of help you make sure you're not over investigating or doing more than you need to do.
I think also, there is perhaps the busier you are as even a senior GP, the more likely it is you're going to refer to the hospital. Whereas actually, if you're not quite so busy because you've got some help, then actually you probably have time to sort it out yourself. So I think you do have to also look at it in the context of the team.
I can also, if I can chip in, Jeremy.
Please go.
I can anecdotally, I can say in 12 years, I've not had a FACEM or an SMO from the base hospitals ever pick up a phone and moan that they're getting crappy referrals from the PAs or overworked and overburdened with poor referrals. In fact, quite the opposite, hugely positive and supportive from the SMOs, FACEMs down at either at Southland or at Dunedin hospitals. So quite the opposite experience, I would say. I can't speak for primary care yet; it's probably early days, but yeah, a very positive experience from our emergency department.
Yeah, thanks, Karl.
Could I say something too?
Andy, cheers.
Hey, sorry. Just to introduce myself, I'm Andy Cook. I'm one of the physician associates in New Zealand. I've been here for a little over 8 years now. In regards to over ordering, I do think, especially the PAs that come from the US, we're very defensive in our medicine, and I would suspect US PAs may order more than maybe our Canadian PAs because we come from this defensive background. You must prove that you've investigated this fully. You must prove that, and you must defend yourself. But I do think as you get used to the New Zealand system, and as you learn those pathways, that gets less and less. And I strongly believe that once we are regulated, then you will also see a drop in some of the investigations, because we are really trying to cover our butts to make sure that we don't miss anything right now as an unregulated profession, because we can't afford that. But I do think that we'll fall right in line with our colleagues once regulated.
Thanks, Andy. Appreciate that input. Yeah, I think one of the things it also highlights is that importance around communication, and to have that collegial relationship and have that feedback. So it's not a whinge and blame system, but rather how do we learn and support and support each other around that. Victoria's just asked in the chat, are we going to talk to the UK experience? Can any of you talk specifically to that, or has anyone else on the call got some experience in regards to the UK?
Well, I think I assume Victoria's referring to the recent kind of bad press that PAs have gotten in the UK, and suddenly there's been this outpouring of kind of protest against PAs, and a lot of bad news about PAs. But what I think is interesting, PAs have been trained and practicing in the UK for dozens of years and have been well supported and well received until just recently, until the last couple of years, 5 years maybe. And then suddenly there's been this push against PAs. The one thing they like to talk about the most is a single case where a young woman died from a PE that was misdiagnosed by a PA, which is terribly sad, but they don't then come back and present all of the statistics about how many undiagnosed PEs happen because of doctors, or how many NPs missed an PE and it had a bad outcome. Um, it, it seems to be kind of a political issue, although I don't really know exactly what it's stemming from. What's going on in the UK right now. There's just been a lot of pushback against PAs, but statistically, PAs are often, I won't say safer because there aren't as many PAs. PAs are statistically at least as safe as doctors, it seems to be, if you really look at the statistics and the numbers.
Thanks, Shelly. And I think it's important to, when we think about comparisons, to also respect the role delineation of each of those professions. And so we're not trying to say everyone should be doing the same job and be equal and so forth, but rather respect where they sit within the team and in terms of delivering healthcare. One of the things I've reflected on with this discussion is that opportunity around, for New Zealand training. And if we do have that we can specifically focus on, the culturally safe work in New Zealand. We're recruiting from New Zealand communities, the referral practice in New Zealand, the test ordering and so forth. And so the opportunity then to mold the role of a PA specifically for our New Zealand and preferably rural context, I think provides real opportunity. So that's a really interesting thing going forward, and obviously hinges a huge amount on what happens at a political level around the regulation side of things, and often decisions outside of our control. We've covered off the majority.
Sorry, Jeremy.
Yeah,
I think the other point is what really excites me is if regulated and it does develop curriculum at tertiary institution level, that one, there's a really good record in the US of PAs training and going back to their Indigenous, often home communities that are underserved. So huge potential there. But all of these, especially health science students coming out of Otago and Auckland, often with no pathway, desperate to get into medicine or dentistry or the like. And obviously we know places are super competitive, but I think that gives these young people another pathway, and particularly to serve our rural communities is really exciting.
Thanks, Karl. And again, opportunity, if we think around the development of postgraduate medical training, how those sort of stepping stones and moving sideways in clinical practice could work into nurse practitioner work, into prescribing, the opportunity for scope. All right, guys, we're coming up on our hour. I think I've covered most of the questions that were brought up in the emails prior to the webinar. So please jump in if you've got last minute questions, and particularly stuff that you want us to follow up down the line. As I say, we'll try and address those specifically and do some follow up as I read quickly the chat as we go along.
One other thing I'd say that we've just sort of discussed it a little more recently, particularly around the communication. I've got a lot of people I have to supervise in my practice, including medical students and trainee interns and registrars and locum doctors who aren't necessarily vocationally trained, often from overseas. And this is one of the discussions we've had around the informal sort of communication and chat we have with our PAs versus often a formal meeting with our overseas locums that has been directed by the Medical Council. And possibly that's done differently around the country with the PAs that so it'd be interesting to hear back from anyone who's a PA who has experience on how that is managed in other areas.
So Scott, I'm sorry, were you talking about the
Do you have a formal sort of debrief with your supervising GP once a week or once a month, or how do you manage that relationship?
Yeah. Well, initially my supervising doc when I first started, before he knew me well and we'd worked together very long, we would have a formal meeting initially after every patient I saw until he kind of knew what I was doing. And then about once a week we would meet, and now it's about every 6 months. It's much more informal. He looks over my ACC charts that I put in and other things. And of course, like I said, we're looking at the same inbox. And so he'll just send me a little task saying, hey, let's talk about this or let's cover that. Or it's much more informal at this point. It's over lunch oftentimes.
Yeah, okay. Well, that's interesting to hear. Yeah.
Thanks very much, Shelly. All right, team. Well, we're hitting our hour, and meetings are important to us all. I'm really happy to follow up with questions and so forth down the track. Apologies, Victoria, responding to a chat. I can't multitask. I've only got one X chromosome, and so apologies if it's a little bit candid, my responses, but we will endeavour to keep the dialogue going as we go along. So I'm sure all of us alike can say thank you very much to our presenters this evening, Shelly, Scott and Karl. It's been a really valuable insight, and particularly, as I say, to understand and to learn and to share some experience around the role of PAs in New Zealand and where the opportunities sit, where the caution needs to sit as well, because I think there's plenty of all of the above as we move forward. But certainly our rural communities really need well-trained, solid clinical workforce, and there's opportunities for us all across that sector. So I'm going to finish up the webinar this evening with karakia. And as I say, please reach out. Really happy to keep that conversation going. And once again, thank you so much to all. So kia tau mai te manaki o te wahingaro, mai runga, mai raro, mai roto, mai waho. Hui e, tāhiki e. Kia ora.
Kia ora.